Hello, my friends. My name is Dr. Saeed Kazmi. You're watching my YouTube channel, and today I've got a very interesting case for you. And that is a case of metabolic acidosis in a 3 years old girl. This is a very interesting case, so stay tuned till the end. And without wasting our time, let's dive in and get started. So, this case, which we saw a few days back, this was basically seen by her GP, and the GP then referred her to the emergency department. The reason for her visit to the GP was because she had an episode of fever, a febrile illness associated with some bouts of non-bilious vomiting, and the mom also complained that she was passing some large bulky stools. So the GP thought that it might be a case of urinary tract infection, so he did an on-spot urine dip. What he found was that the urine contained 4 plus of ketones. So he could not confirm a UTI, but he was worried that why the urine is showing 4 plus ketones. So they advised that child and her parents to go to the A&E to get further worked out. When now this girl presented to the emergency department, she was triaged by the nurse, and the nurse found out her that vitals were absolutely stable. But given the fact that she had a history of ketonuria, she decided to do an on-spot finger prick blood glucose and also a finger prick ketone levels. Now, what she found out that the blood glucose was low. It was 3.1 millimole per liter at the time of presentation, while the ketones are quite high. They were 5.4 millimoles per liter. So she flagged this case up to the doctor. The doctor said, okay, well, fine, because this is hypoglycemia. The blood glucose is on the lower end of the normal. She should give her some dextro gel, and then the doctor would see her. So this child was given oral dextro gel, was put on the bed. Then the doctor went and examined this child. Now, by that time, she already had the dextro gel. Now, the doctor took the history, which was the same. She had a few days of non-bilious vomiting, 2 to 3 days, mild fever, few bouts of bulky loose stools, and that was it. I mean, on examination, there was nothing abnormal. Throat was fine. Chest was clear to auscultation. There was nothing on the abdominal examination. A urine test was again done, and it shows the ketone levels in the urine, that the ketonuria was still present. It was 4 plus. There were no leukocytes, no nitrites positive on the urine dip. So the doctor thought that this could not be a UTI. So it was decided that she should be further walked up. So an cannula was passed, an on-spot blood gas, venous blood gas was done. And I will show you that in a moment. And at the same time, rest of the bloods like full blood count, CRP, LFTs, UAEs, and all those things, the samples were taken and sent to the lab. Now, what the initial blood gas, venous blood gas showed is over here. Now, you can see that this girl has got a pH of 7.33, which is on the acidotic side. Now, if you look at the PCO2 and if you look at the bicarbonate, so both are reduced. So PCO2 is down to 4.1. The normal is 4.5 to 6. The bicarbonate is also low. So they both have moved down. So this is a metabolic problem. So this is metabolic acidosis. If you look at the glucose, it's still on the lower side, 3.1, despite this girl having some dextrogel. So the glucose is not coming up. Then you look at the lactate. Lactate is absolutely fine. So there's no lactic acidosis. So what you are seeing on this blood gas is that it is primarily a metabolic acidosis. Now, if you also do a bit of further calculation on this blood gas, and if you look at the sodium and the potassium and the chloride things, and if you do those sort of calculations, you find out that this is a normal Anion gap metabolic acidosis. So fine, you can see normal Anion gap metabolic acidosis in vomiting, in diarrhea, but the problem here was low blood glucose. Since this was acidosis, it was decided that this girl should be given a fluid bolus 10 mils per kg. So some IV normal saline was given, and the blood was sent off in the meantime to the lab. Now, after some time, what happened? The lab called and they said that are the doctors and nurses sure that the sample that was sent for biochemistry was not hemolyzed? And the reason was that on the chemistry analyzer, they found out that the calcium and the potassium levels are quite high. They Their reading was 7 point something. When they confirmed it with the board, the doctors and nurses, they told them that this sample was not hemolyzed. So they said they will rerun the sample to see if it is the same elevated potassium. Now, this also alerted the doctors, and they decided to do a repeat blood gas. Now, the CRPs was also mildly elevated around 13, but nothing significant. So, when a repeat blood gas was done, that is in front of you, and you can once again see that despite this girl having dextrosol, despite this girl having a bolus of normal saline, she is still acidotic. The pH is 7.31. The bicarbonate is still low. Lactic acid is normal. You can see it's like 1 point something. So that's absolutely normal. The blood glucose has further dropped down, 2.8. So there's a persistent hypoglycemia. If you do the calculation once again, this is normal anion gap metabolic acidosis and hypoglycemia not responding to dextrogel, and the acidosis has not improved despite some fluid resuscitation. But interestingly, if you look here, the potassium is also elevated. Now, the lab also alerted you towards a high potassium level, and this potassium level is also high. Now, this girl was fine. She didn't have any cardiac problem, anything. ECG was absolutely fine. So it was decided that we are dealing with a metabolic problem, a metabolic acidosis with hypoglycemia and hyperkalemia. So we need to find it out. On the face value, it looks like a gastroenteritis, but there was something more deep to it. So let's talk about the differentials when you come across this type of condition in which you have got a normal anion gap metabolic acidosis with hypoglycemia. And here there are two things. It's not only the acidosis, you've got a persistent hypoglycemia and you have got hyperkalemia. So how to work out this situation? So let's talk about some of the differentials and then how do we further work up to differentiate between those differentials. So the three important differentials that you should be considering here are idiopathic ketotic hypoglycemia, number one. Number two, Addison's disease or adrenal insufficiency, as we call it. And number three is type 4 renal tubular acidosis. But before we discuss that, because this girl had persistent hypoglycemia, and if somebody has got hypoglycemia persistently, you need to treat it. So we decided to start this girl on our dextrose maintenance fusion. So normally the dextrose for hypoglycemia is given at the rate of 6 to 8 milligram per kg per minute. So this girl was probably 14.5 kilogram. So on a 10% dextrose, starting her on 6 milligram per kg per minute, it was calculated to be 52.2 mils of 10% dextrose per hour. So she was started on this infusion. And it was decided that we would admit her to further work up and find out what are the reasons for this acidosis, for this hyperkalemia, and this for persistent hypoglycemia. So coming back to the differentials, as I told you, the first important differential in a child who has got hypoglycemia, which is persisting and it is precipitated by an illness, you should think of idiopathic ketotic hypoglycemia. What does idiopathic mean? Nobody knows. It's something which is like the cause is essentially unknown. Ketotic means that it is associated with ketonemia. And hypoglycemia, it's low blood sugar. So what happens in idiopathic ketotic hypoglycemia is when the child is under stress because of a viral illness or anything, the body is not able to utilize the glucose reserve. So what happens is that the alternative sources of energy, alternative sources of fuel, they kick in. So the body starts to produce energy from proteins, from fat. So as a byproduct of those things, what happens is that there is ketonuria. So the fatty acids increase in the blood. So ketone bodies are increased in the blood. That gives you ketonemia, as we had in this child, ketone levels of 5.4. And when the ketone levels, they jump up in the blood, they also start appearing in the urine. So a ketotic hypoglycemia simply means that the body is responding to hypoglycemia by using alternative sources of energy. Yes, if you have got hypoglycemia and there are no ketone, then you should be worrying about like some fatty acid oxidation defects in which the ketones cannot be utilized. So the first important differential diagnosis here is idiopathic ketotic hypoglycemia. The second one that you should be thinking of, where there is low blood glucose, low sodium, and high potassium, is Addison disease. Now, Addison disease basically means adrenal insufficiency. So the adrenal gland that produces cortisol, for one reason or the other reason, it's not able to produce enough levels of cortisol. It could be because of the problems with the adrenal glands themselves, because they are destroyed by some disease process, or because they are not being pushed to produce enough cortisol because of problems somewhere else. For example, a problem in the pituitary gland or a problem at the level of hypothalamus. So all of these combinations would give low levels of cortisol, in which what happens when the child is under stress, they start vomiting, their blood pressure is always on the lower side, their sodium is low, and their potassium is high. Now, if it is primary adrenal problem, usually what happens as a compensatory mechanism, ACTH would increase in the blood, and that ACTH would cause some hyperpigmentation as well. So if you got low blood glucose, if you've got a low blood pressure associated with low sodium and slightly high potassium, and the child has got hyperpigmentation, it means a primary adrenal insufficiency. But sometimes there might be a problem at the level of pituitary gland or at the level of hypothalamus. In that cases, the ACTH would be low. There's nothing wrong with the adrenal gland, so the child would not be having hyperpigmentation, though they would have other problems like hypoglycemia and low sodium. So Addison disease or adrenal insufficiency should be the other differential that you should keep in mind. And the third thing here is type 4 renal tubular acidosis. Now, there are three types of RTAs: type 1, type 2, and type 4. There's no type 3. Now, type 1 and type 2, they are known as distal and proximal renal tubular acidosis. They are associated with metabolic acidosis, but the hallmark of type 1 and type 2 is hypokalemia. So, they are always associated with low potassium. Here, if you see, there is high potassium. So the only type 4 renal tubular acidosis that gives you hyperkalemia. So that is the third differential that you should keep it in mind, given the fact that this child has got metabolic acidosis with hyperkalemia. So the type 4 renal tubular acidosis can also be the cause. Now, the reason for type 4 renal tubular acidosis is that there is a problem in hydrogen potassium co-transport channels. What happens is that the hydrogen ions and the potassium ions cannot be sort of exchanged for sodium. So what you get is a high potassium levels, and retention of hydrogen ions lead to acidosis and hyperkalemia. So it can be because of what we call end organ resistance to aldosterone. We call it pseudo hypoaldosteronism, or some problems in the renin aldosterone or renin pathways as well. So usually it's the end organ receptor, resistance to the aldosterone, which gives you type 4 renal tubular acidosis. So how do we work up to know like which of the differential is the cause for acidosis? So the type of workup, now these type of children, they need to be admitted, and the types of workup that you would do is, number one is blood cortisol level, because in case of adrenal insufficiency, the cortisol levels would be low. But that would only give you an idea that there is something wrong in this whole axis of the how the adrenal glands work. So you have to further do some tests to see whether it's the primary, the secondary, or the tertiary adrenal insufficiency. So you have to check the ACTH levels, whether they are high or low or normal, and you have to do what we call as short synectin test as well, to see where the problem lies in this whole axis, whether it's the hypothalamus, whether it's the pituitary, or whether it's the adrenal glands themselves, or whether it's the end organ resistance to cortisol. The third important investigation that you need to do is renal and adrenal ultrasound. Because adrenal ultrasound will give you an idea of the morphology of the adrenal gland, if they are fibrous or if they're being destroyed by a disease process. Renal ultrasound will give you an idea of how the renal anatomy is, because certain cases of obstructive uropathy like nephro or urolithiasis can be associated with type 4 renal tubular acidosis. So it's important to do a renal and adrenal ultrasound as well. And to further look into the possibility of a type 4 renal tubular acidosis, you have to do aldosterone levels, you have to do the blood renin levels, and you also have to check the urinary electrolytes level to see whether it is type 4 renal tubular acidosis. So that way you would be able to reach the underlying diagnosis, what is causing this metabolic acidosis. So remember three things for normal anion gap metabolic acidosis with hyperkalemia. Remember, it could be Addison or adrenal insufficiency, it could be type 4 renal tubular acidosis, or sometimes it could be, if it associated with hypoglycemia, it could be idiopathic ketotic hypoglycemia as well. So it's very important that you admit these kids till the time that their blood glucose levels are not stabilized. They need to be on the dextrose infusion. The dose is 6 to 8 milligram per kg per minute, and then you can calculate how much it comes out to be per hour. You can combine it like with 0.9% or 0.45% normal saline as well, and you have to do these investigations to see what is the underlying diagnosis. So remember, idiopathic ketotic hypoglycemia, remember adrenal insufficiency, remember type 4 renal tubular acidosis. So this was an interesting case, and with the help of this I tried to explain the three important differentials and how do you further work up these differentials to reach a final diagnosis. So I hope you have learned something from this interesting case, but if you still have got any questions, put it down in the comment section below. I'll be more than happy to answer this. So have a very nice day, take care, and bye bye.